Welcome to OsteoBites. My name is Anne Graham. I'm an osteo warrior and executive director of MIB Agents. Today we have a really interesting topic on OsteoBites, courtesy of Dr. John Doski, Division Chief for Pediatric Surgery and the University of Texas Health, San Antonio, Department of Surgery. He will discuss an upcoming randomized trial comparing open and minimally invasive thoracoscopic surgery. Really, it's so exciting. We've been talking about this for a little while at Factor, and anyway, so excited to hear this come together. Dr. Doski's medical degree is from the New York University School of Medicine. He completed his general surgery residency at the State University of New York at Stony Brook. Following his completion of his time with the US Air Force, he completed a fellowship in pediatric general and thoracic surgery at Children's Medical Center of Dallas under the direction of Dr. Phillip Guzzetta. His clinical interests include pediatric surgical oncology and resident and medical student education. Dr. Doski is a fellow of the American College of Surgeons, a member of the American Pediatric Surgery Association, and the Children's Oncology Group. So he knows what he's talking about. Before we get started with this conversation, a really big announcement that MIB Agents annual Factor Conference is on and in person in 2022. It's happening June 23rd to 25th. This is a time when our community of doctors, researchers, patients, and patient families will be in San Diego, and we all work together to make it better for kids with osteosarcoma. Researchers and doctors, please submit a Factor abstract if you'd like to speak at the conference. Those are due on February 25th. And we also have travel awards available for osteosarcoma doctors who might not otherwise be able to attend. In the meantime, Dr. Doski, could you get us started with an introduction, please?
You bet. So it's my distinct pleasure to go ahead with you, with Christina, and with Ryan to present a long-standing labor for about the past 8.5 years working towards this moment. The randomized controlled trial is now about 48 hours old. We had delivery of a healthy baby protocol this past Tuesday. So I'm really excited to go ahead and present this morning. This is a topic that hasn't really received much attention in the past, but it's certainly appropriate and necessary. And so thank you for the opportunity to present this morning.
Hi, my name is Ryan. I am a osteo warrior. I was diagnosed all the way back in 2014. I had a limb salvaging surgery. I unfortunately relapsed a year after I finished treatment and had a VATS surgery to remove a single nodule. However, ever since I've been cancer-free, and I am currently working in the Refinement lab.
And I am Christina Iptoma. I am mom to Osteo Angel Dylan, and I'm also the director of scientific programs for MIB Agents. And I am very excited to hear Dr. Doski present today.
All right, so the topic this afternoon deals specifically with pulmonary metastasis in children with osteosarcoma. Having Ryan participating is going to be putting a unique perspective on it. And so I'm really looking forward to his input. During the presentation, if there are things that are coming into chat, I have asked Ryan and Christina to go ahead and interrupt me. I want to try and have this as interactive as possible. This is one where we have spent a lot of time thinking about all of the different ramifications and ins and outs. And so if something isn't making sense, or you have a view of things, we'd love to hear about it. So to begin with, and this is one where the instruction was to have a little bit of sort of lower level stuff and a little bit higher stuff, and then we'll get into the technical stuff in the last half. So osteosarcoma, this should be fairly straightforward stuff. About 400 cases in the US a year. At the initial presentation, about 20% of kids are going to have metastasis. Of this, about 75% of this, 80 kids, are going to have metastasis to the lungs alone, and that becomes really important. An additional 100 kids are going to develop lung metastasis at a later point after the initial management for the localized disease. Going back to 1927 is the first description of taking out disease that has gone to the lung. Over the course of the last several decades, there have been all kinds of studies performed where more aggressive surgery was warranted to improve survival. That is certainly the mantra in osteosarcoma, where all pulmonary disease needs to be eradicated, such that in the pediatric surgical training, and we go to pediatric surgery school, open thoracotomy had been the mainstay of appropriate oncologic surgery for this patient population. At the time, it would require a fairly substantial incision where you would be able to have your hands in there and feeling all of the different lung surfaces. The pulmonary metastatic disease of osteosarcoma has a very firm, very sort of like sand granule feel to it that you can pick up with palpation. And that sense is called haptic sense. That becomes really relevant when we start discussing this protocol. And having said all of that, all of the disease needs to be removed. Almost all of the disease in osteosarcoma is on the outer lung surfaces. It's rarely centrally. And so as a result, we just have to take pieces of tissue that have this abnormality out, and we use a stapling device to go ahead and wedge it out. Now to go ahead and shift gears a little bit, I want to talk about minimally invasive surgery. Jacobaeus back in 1910 is credited with putting in a couple of lenses in a cylinder and coming up with an instrument that he was able to go ahead and use to look into the airway of individuals. Since that time, that technology and that principle has exploded so that it is used everywhere in clinical medicine today. Back in the 1980s, the gynecologists started and subsequently picked up by general surgeons to go ahead and do things called laparoscopy. So all of this falls under minimally invasive surgery. Cardiovascular, they're doing minimally invasive with small incisions and scopes and specialized instruments. Their neurosurgeons are doing ventriculoscopy, where they put a scope into the ventricle of the brain. There's fetal surgery, they call it fetendo. And so there's all different applications, as well as the video-assisted thoracoscopic surgery, or as you heard Ryan mention, VATS. Oh, back one. And since that time, there has been extensive academic and industry efforts. The instrumentation has become super. The visualization is amazing. And so the advantage of the minimally invasive, same operation, huge principle, but smaller incisions, less pain, shorter hospitalization, and a faster recovery. Disadvantage, you are dependent on the technology that you have in your hand, and you're not able to feel the surfaces, so you have an impaired haptic perception.
Can I ask a question real quick?
Yes.
On VATS, it seems like there'd be less opportunity for infection as well, because you don't have such a big band of cut.
That is correct. There should be decreased chances. Generally speaking, hibiclin shower beforehand, generally speaking, IV antibiotics, you have an infection rate of about 3 to 5% on the open procedures. The thoracoscopy is a little bit less, hasn't really been studied or compared. But so yes, you're right, but it hasn't risen to the level of, oncologic significance to say, well, we're going to change practice. Yeah. But yes, that is a role as well.
Can I just add one other kind of funny thing? When I was being treated in pediatrics and they were talking about doing an open thoracotomy on me, the way that they explained it to me, and I think it was because I was in pediatrics, was it's like your lungs are like a crunchy, like a sandwich, right? 2 pieces of bread and spread in between the bread is crunchy peanut butter. And putting your hands in and feeling the bread, you're feeling for where are the crunchy peanut butter parts.
Yes.
And then they go in and they pop out the crunchy peanut butter parts, the nuts.
That's correct. So they would make sure that you had no peanut butter left. Yes.
Right. At least the crunchy parts. That was the problem. Anyway.
I will say you were treated by very creative people. Yes, a little more imaginative than my own presentation, but yes, take the crunchies out. All right, and so now to go all the way up to 30,000 feet, how do advances in medicine occur? I can sit in an OR lounge. Somebody tells me, hey, I did it this way. I can say, hey, that sounds like a great idea. Let me try it. Is that the right way to do it? Absolutely not. When you start looking at additional ways, animal studies are helpful and informative, editorials and opinions, informative, but it has to be built, it has to be practiced on a much more solid base. Retrospective reviews, where you go ahead and go back and look at different things, you look at different outcomes, you look at case reports from the single institutions. Cohort studies, where you go ahead and decide what you're going to look for, and then you collect data prospectively on those data points that you're looking for a given process, is a reasonable and somewhat better way than the simple idea. But it's really not where science needs to be, and it's definitely not where oncologic therapy needs to be. The systematic review, the subsequent meta-analysis, collecting the data from the systematic and reanalyzing, those are helpful. But when it comes down to it, if you need to have a question answered, you want to conduct a randomized controlled trial. That's where you're going to be taking two reasonable paths, both of them scientifically justified, thoroughly researched, and you're going to be taking one group of patients and you're going to be sending them back and forth to one or other therapy to go ahead and then compare and come up with a decisive answer. So a randomized controlled trial truly is the gold standard for the advancement of medicine. So back to osteosarcoma, large cooperative studies have been conducted over the last 3 decades over in Europe as well as here in the US, combined studies with Uramos, where the standard practice has been an open thoracotomy. Occasionally, if there's disease on both sides, then they go ahead and split the sternum and then can approach both lung fields at the same time. But it's an open procedure. In the last 10, 15, 20 years or so, with advocacy for and improvement in the practice of minimally invasive surgery and specifically video-assisted thoracoscopic surgery, there are some institutions that are publishing data where management has been with video-assisted thoracoscopic surgery, different than the standard. At the same time, you have institutions that are publishing an even more aggressive approach to an open thoracotomy. And to that end, some institutions would go ahead, and if the person presented with disease on one side, you would go ahead and recommend exploring that one side and exploring the other side that didn't have any disease, looking for disease. And they would report the finding of 10, 20% of those patients having disease on the other side. So I label this slide entropy, which is decline into disorder, where at the end of it, the challenge is what is the most appropriate oncologic surgery for this process. And so that's sort of the background of what we were faced with. So what to do about it? The conversations began back in 2013 about conducting a prospective observational study that I had referenced before. It would give us some information. It would not really be intrusive because we are just collecting what people do. And so we approached the COG leadership about that, and we're in talks. Concurrent with that, Dr. Gorlick and his associates at the time at the Montefiore conducted through the Connective Tissue Oncology Society a survey, which they conducted it in 2014, showed a wide divergence of treatment based on a 0.5 centimeter nodule, 1 centimeter nodule, 2 centimeter nodule, 1 nodule each side, all kinds of variables put in, and the management was all over the map. So clearly, pulmonary metastasectomy, there's a base understanding that you need to take the disease out, but there's a clear wide difference of opinion in the best approach. And that sort of worried us in terms of, you know, the kids with osteosarcoma go through so much that we really do need to try and do the very best we can. That's in the eradication of the disease, But if we have a capacity to go ahead and make the therapies appropriate, but a little bit better tolerated, then we need to consider that. So as a result, the COG went ahead and said, well, are surgeons willing to do that? Well, we conducted a survey in 2016, got about 17% of the surgeons in North America to respond. And you can see for a given process, the two specific pathologies, 3 lesions on one side, 2/3 would do it open, 1/3 would do it VATS. 5 lesions, 80% are going to do it open, 20% are going to do VATS. Contralateral exploration, a full 29% are going to explore when there's no disease seen on the other side. And then the final question, would they be willing to participate in a randomized study? And 85% of the pediatric surgeons that responded said yes, they would. Now we're faced with a situation that we're going to try and conduct a randomized study. It becomes really tricky. And so with that, in 2018, a group of surgeons within COG, we call ourselves the PSORC, collected 206 cases and found that there was a significant percentage of both open and video-assisted procedures, and we found that there was equal survival. And so that's when I first came encounter with the word clinical equipoise. Since that time, I have heard equipoise used so often that I'm going to name my next dog Equipoise. But equipoise means that it is balanced and appropriate, and the two choices, there is nothing untoward or bad for the pursuit of. Still trying to get to what the right answer is for metastatic osteosarcoma. And then I was able to travel at Ann's invitation to Florida and present at the January 2019 meeting, and was able to, with Ryan there, go ahead and present some of this material. And at the time, 69% of the folks that were there responded with a willingness to consider participation in a randomized controlled trial. We consider that a really important thing because there is so much dogma to some of this process that it is vitally important that we understand what we're asking of folks, as well as what those folks are going to require from us. And so seemed to be sufficient willingness such that we continued to put the study together. Ran into all kinds of headwind about superiority studies versus non-inferiority studies. Dr. Adamson, who was the head of COG at the time, actually put together a special surgery school for me in Philadelphia with the statisticians, with other folks, and with a couple of other tricky surgical questions. We came up with a way forward.
I have 2 cents to add here, if I may. I think one of the from a patient and a parent perspective, not a parent of an osteo warrior, but a parent period, and then having had this disease, I think one of the key things to having this 69% willingness from the patient families was there was a part of the presentation where you talked about, and the surgeons who were presenting with you as well said, and you had said as well, that should you go in with the video assisted thoracotomy and you find that there's extensive disease, or there are things that you didn't know were there, that you could switch on a dime and you could go over to open thoracotomy. And yes, the goal always is to do right by the patient and not by the study. And I think that's a really important distinction that as a patient community, I think we all needed to hear that component, that always do right by the patient first. And the randomized bit goes away, and now this is a must do.
1000%. Yes, and in point of fact, we have that built into the protocol, where if at any time during the operation there needs to be a different clinical pursuit, then that will be pursued to do what's best for the patient. Yes. And so as a result, as I said, it's 48 hours old. AOST 2031 is a phase 3 randomized controlled trial comparing open to thoracoscopic management of pulmonary metastasis in patients with osteosarcoma. Going through the different NCI processes, they have identified the adult institutions. SWOG is the Southwest Oncology, the ECOG Akron is the Eastern Consortium, and then Alliance is run through the American College of Surgeons. And so we've actually had significant interactions with each of the 3 adult cooperative groups. There's actually a 5th one, National Radiation, but this is not really a radiation study. So we have the 4 main clinical groups of the NCTN that are aware and will hopefully be participating. So what is the study? It is a COG study, but it's going to be able to open in other NCTN institutions. It is going to be randomizing patients with limited disease. We use the term oligometastatic, and we have described that as 4 or fewer lesions that are pulmonary metastatic that will be randomized to open or thoracoscopic surgery. All kinds of different challenges along the way to get this study through. One of the challenges is the heterogeneity of the disease. The fact that you are going to have some patients with very few, you're going to have patients with 1 lesion, you're going to have patients with multiple lesions. And when you start getting into all of those variables, it makes it very difficult to have a cohort that you compare back and forth. And so as a result, we have targeted at 4 or fewer lesions because from a surgical point, we can get out 4 lesions on one side. When you start dealing with 10 or 15 or 20, you cannot, and it's unreasonable to do that, and that's not right for the patient. As I said, we're most enthusiastic about the fact that we have extensive involvement of our imaging brothers and sisters. Biology is humongous, and we have actually pulled in quality of life because we think that is an important component to try and figure out if that's going to be impacting one is better than the other. We have estimated 225 patients with 25 that are not going to be able to process all the way through. This is over a 4-year period with a 6-month extra window. It will be broken down into 6 separate strata or groups to compare. It's going to be newly diagnosed patients that have standard and poor risk disease. The poor risk would be more than 1 lesion, would be a certain viable tumor percentage above 10%, or would be bilateral disease. The standard risk would be 1 or just unilateral disease. Then we have that's the 2. The next 2 would be relapse patients that are going to be planned to have chemotherapy. And then the last 2 would be relapse patients that would not be getting chemotherapy. And it was an important distinction for the NCI to have relapse with chemo or relapse without chemo, again, trying to address so much of the heterogeneity which could negatively impact our ability to come up with a solid conclusion at the completion of the study. As I said, we had a big meeting in Philadelphia. There was a lot of discussion about superiority versus non-inferiority. Non-inferiority studies, for those that don't know, and I didn't know this either, they are humongously long and take enormous numbers to try and determine relevance. So as a result, we have set the statistics to have it as a 15% margin of superiority that open is better than thoracoscopic surgery. The eligibility, again, related to heterogeneity, but allowing this to occur in the adult consortiums. We have it 50 years of age or less. There needs to be control of the primary disease. And this is another important one. If the person doesn't have control of the primary disease, then we're not going to really know the impact of our surgery. If there's still disease there, then they may go ahead and not do well from the primary disease, and the lung would be fine, but that would be lost. The disease can only be in the lung. We can't have it in any of the other bones or structures that it may go to, again, impacting our ability to go ahead and say, this makes a difference. And then the last, as I identified before, is going to be 4 lesions or less, the thinking there being that we can approach it either as an open or a thoracoscopic, and we feel comfortable and secure in discussing that with our patients. This was added on a real-time preoperative central radiologic review to confirm the appropriateness of the enrollment. And this was a big NCI point. We were initially going to be having the institutions determine metastatic disease, but along the way, it was felt important enough that if we're going to be having patients participate, we need to be 100% certain of what we're looking at. And so we have about 10 radiologists that are going to be involved. And I'll get to the bilateral in just a moment. We're going to have about 10 radiologists involved. We are going to be having a less than 72-hour turnaround return to the institution that will confirm. But in addition to that, that central radiologic review is going to be very useful. We're going to be recording all kinds of information as to the nature of the lesion. So we're going to have this centrally collected. We're going to have the surgical data. We're going to have the pathology data. And we are now going to be able to look at the process through, and this was disease, this wasn't disease kind of moments. And so we're hoping to get a lot of important information on the imaging side. Institutional localization efforts are permitted. That means, as I said before, you don't have haptic sense on the thoracoscopic, but we have gotten really good with radiologists going ahead and placing things directly into a lesion to take out. They can inject it with methylene blue. We can give something in the intravenous the day before that is going to make this lesion pop out as a bright yellow. There's all kinds of localization efforts that are being done by institutions all across the country. And so we are actually going to be collecting that data, hopefully to inform which are the best localization efforts that result in the highest percentages of disease, as well as the ones that don't work so good. It will be randomized to open versus VATS. This will be unilateral and bilateral disease. This is going to be, the only caveat is that there can be 4 or fewer lesions. So if a person has bilateral disease, we are going to be bringing those patients into the study as well. They can be done where both surgeries are done in one day. It can be staged so that the second surgery is done within 2 weeks of the first surgery. We're going to be collecting information for the localization as well as all of the quality of life for both of the surgery. The whole thing needs to be done within 28 days from the date of imaging to diagnose the metastasis in anticipation of surgery. Important clarification: for a patient with initial metastatic disease, they're going to go through all of their therapy initially, including the resection of the tumor. Then the expectation is they're going to address the chest disease, the pulmonary disease. The CT scan is obtained, and at that point, that's the 28-day window for the initial presentation. Recurrence patients are generally going to be having a CT scan. They say, oh my gosh, there's something there. That's going to be their 28-day window. So a little bit of a difference there, but 28 days is important because we don't want to have the disease change too much. The quality of life studies, the Quality of Life Committee of COG is thrilled about this. So with the randomization, they're going to be conducting surveys before the operation to get a baseline understanding of how the person feels. They're going to be getting an initial pain survey at 48 hours. We're going to be doing one at 7 to 14 days, which is a guesstimate of discharge from hospital. And then we're going to be getting one at 4 to 6 weeks with thoracotomy patients still, potentially impacted or not by the surgery. So the quality of life is a really big piece. And then we're going to be getting CT scan of the chest every 3 months for the first 2 years, covered by insurance. And then the institutions will be maintaining CT surveillance after that point and they will be and they will be the ones that determine if there is any disease found in the chest.
Oh, Dr. Doski, we had a question come in about bilateral disease and how that would be handled. And I think you mentioned that you could maybe do the either the thoracotomy or thoracoscopy on both sides.
Yes.
Could you elaborate that on a little bit? And could you have, are you still eligible as long as you have 4 or fewer lesions per side?
Correct. That is exactly correct. 4 or fewer lesions per hemithorax or per side. If there is bilateral disease, then we are going to be enrolling those patients as well, provided they in the institution feel that this is appropriate. Yes.
And in the very beginning, you had mentioned a sternotomy, and I know my son had a couple of those. And so how does that play into this for bilateral disease? Because that is, you know, has been an option for bilateral disease.
We're going to be, we're not being too prescriptive in terms of the bilateral. It's an open procedure, and so it leaves wiggle room because there are acknowledged institutional preferences, bilateral thoracotomy in some big places, sternotomy in others. The bilateral thoracotomy is a bigger physiologic impact on the person having it done to both sides. Sternotomy has its people that advocate against it because they say they can't get as good a feel of the posterior lung field. So acknowledging that there are advocates of both, we will be collecting the data on both to hopefully also inform. As I said at the beginning, there really has never been much attention paid to nor a metastatic study. So it's sort of new ground here. All right, and so to get a little bit tighter into the weeds, and this is some of the stuff that we've gone through in the last 2 years in refining the study. So as I said, we want to try and be able to deal with the patients in a very similar way. So we have a prescription of how many lesions. We have a prescription of what these different radiology pieces are going to look like. This is one where the last phase 3 had 3 lesions of 5 millimeter or more, or 1 lesion of 1.5 centimeter or more would meet criteria for pulmonary metastatic disease. Now, in the 20 years since that study existed, this has changed dramatically, and this is one where we are routinely clinically calling metastatic disease at 3 millimeter. So we are going to be lowering our metastatic threshold. Again, this is going to be central radiologic review to go ahead and confirm appropriateness, to have at least 1 lesion that's going to be 3 millimeters or greater. None of the lesions can be bigger than 3 centimeters. The concern there being that you're going to be doing a much bigger operation and you're going to have to deliver that thing through a hole. And so as a result, 3 millimeters generally not going to be amenable to thoracoscopic surgery. As I said before, for minimally invasive, you want to try and do the same operation. We did a lot of work related to the diagnostic criteria. And so we've come up with a subjective certainty of greater than 90% or suspicious for, which is greater than 75%. And so the 2 criteria, 5 millimeter or greater, and calcified are going to be consistent with suspicious for if there's demonstrated interval growth, if it is a solid lesion, if it's not subpleural, if it occurs with other nodules. There are actually other radiologic criteria that we're going to be assessing for in the process of the central radiologic review. And so we should be able to get a whole bunch more information about the ultimate nature of these nodules that are going to be taken out. The real-time radiology review confirms eligibility, and then our radiologists are going to be processing and going through the additional radiologic features. As I said, the scan at 8 to 12 weeks post-op, and then every 3 months or so. And this is going to be a thoracic event when the patient may have a new nodule seen. That's going to be called by the institution, and that's going to be actually our primary scientific objective. So as I said, the other disciplines, pathology. So in all of the COG studies and all of the studies that have been conducted, there has never been a systematic collection of metastatic specimens for sample. This is huge. And so this absence of tissue has made it extremely difficult for researchers to go ahead and gain additional insight and information comparing the original tumor to the metastatic tumor. Are there things that make it metastasize? Are there things that we can go ahead and affect? So they are going to be creating tumor models from this, and with hopefully 250 patients, we have an extensive way to process the tissue. The resected specimen is going to be delivered fresh to pathology in a sterile container with the site that it was obtained from. They're going to be obtaining blood samples, and this is a really, really big area of oncology now, where liquid biopsy and finding out where they have detection mechanisms in place now to detect below the billionths. And in that kind of a setting, looking to see if there is a specimen of blood that can tell us that the patient has metastatic disease. We're going to be collecting that after enrollment when the CT scan shows pulmonary disease, and then we're going to be collecting specimens at a later date to go ahead and assess for that signature in the bloodstream as well. The local institution is going to be doing what it normally does. We're going to be asking them to assess the surgical margin. The microscopic sampling is something that we've really never paid much attention to as surgeons or pathologists. We take a lesion out. And when it's a pulmonary metastatic lesion, we hardly ever pay as much attention as opposed to when the primary osteosarcoma is being managed, where they go crazy with the R0, R1, and R2 resection. So we're going to be hopefully getting some information there. As I said, the quality of life is going to be is really exciting. It is going to be collected on RedCap. It is going to be phone, where we're going to be sending out a survey. At this point, even babies have their own cell phone. So we're going to be sending out a questionnaire to the cell phone for the individual to go ahead and answer some questions. We're going to be using PROMIS, which is a validated international use. There are PROMIS questionnaires for children as well as for adults. So we'll be benefiting from both of those. The PROMIS 25 is children. The PROMIS 29 is adults. We're going to be looking at the upper extremity function. As I said before, thoracotomy can be significantly limiting related to the trapezius and the latissimus dorsi and the serratus anterior affected with thoracotomy. We're going to be getting an initial survey prior to the operation. We're going to be collecting a single pain score at 48 hours from the operation. This should actually be interesting because there are some people who have VATS where they're home the same day or the day after. And so, you know, being able to go ahead and validate this, we've tried to be fairly thoughtful, but also maximizing what we're going to learn. We're going to be collecting pain medication administration data that will also be used. As I said, we'll collect the post-op 7 to 14 days. That's the old school version of about time to go home. And then the 4 to 6 weeks, you're sufficiently recovered from the immediacy of the perioperative events. And we're going to be looking again to see how things have returned, hopefully, to some baseline.
We have a question.
Yes.
It says, are you using both quantitative scales and qualitative tools for assessing pro?
Yes. In terms of the quantitative, we are going to be giving them scales to go ahead and fill some of the stuff out. There are other areas of the questionnaire that are a simple yes or no, but all of it has been validated. The only scales we are using are the PROMIS measures. This is being orchestrated through Katie Greenzang and the folks up at Harvard. And with the PROMIS 25, as well as the upper extremity questionnaire, I think there are 8 or 10 questions to it, some of them with scales and some of them with simple yes and no. So to continue on, so the sort of the boring stuff at the tippy end is mostly related to the research questions. And so the primary question, as I had indicated before, is going to be looking at if and when there is a recurrence of disease in the chest. We call that thoracic event-free survival. We are going to be determining that on the basis of the institution obtaining the CT scan in the postoperative period. And we are going to say that open procedure is 15% better than thoracoscopic procedure. Numbers less than that are going to be significantly impactful when it comes to considering the other data that we collect. The secondary objectives to determine if open surgical resection is superior to thoracoscopy for event-free survival. The difference between event-free survival and thoracic event being that you have recurred somewhere else. And that was an input requested along the way by some reviewers. The secondary to determine if open surgical resection is superior to thoracoscopy for overall survival. So if you go ahead and have thoracoscopy and you go ahead and have a recurrence that is sooner, but you go ahead and then have additional 2 or 3 thoracoscopies over the next 8 or 10 years, what is the overall survival? And is this an appropriate way to approach it? And then the last one, to determine if thoracoscopy is superior to open surgical resection for postoperative pain interference in patients with resectable oligometastatic pulmonary osteosarcoma. There was a study in Europe 2 years ago where they compared open and thoracoscopic surgery for lobectomy for lung cancer in adults. And so this is a very relevant and a very important question to try and determine within this special population. And so I see qualitative would be open questions in which patients can respond in their own words. No, it's going to be a yes or no in terms of the data collection that we can access. And then the exploratory objectives, we have surgery and imaging objectives. We are going to be very interested in surgical complications. Did the patient have required transfusion? Was there significant blood loss? Did they have something happen during the operation that was significant and impactful? We have different types of adverse events. To compare patterns of recurrence, this gets into the early presentation where I was talking about people, 29% of the APSA population would advocate for a contralateral exploration in the absence of unilateral disease. So we want to compare the patterns of recurrence, comparing both methods. We want to go ahead and find out what people are doing to localize to find out the relationship better or worse with completeness of resection and how the patients do and whether there really was disease there. We are going to be spending quite a bit of time looking at this central reviewed imaging to go ahead and get as much information as we can from what we're looking at on the CT scan. The CT scans have got immensely more detailed over the course of the last 10 to 20 years. So we're pretty excited about that. And so some biology and quality of life, as I said, with metastatic tissue that we are going to be very deliberately accumulating, we should be able to generate well-characterized and clinically annotated, meaning is we're going to be relating it back to the primary tumor and how the patient does, distributable models of osteosarcoma for people to use. We're going to be collecting and banking the pulmonary metastatic lesions, the paired lesion, which is the primary disease. We are going to be collecting the blood samples, specifically looking for the liquid biopsy approach. As stated, we are going to be collecting the patient-reported outcomes, comparing between surgeries. We're going to be looking at functional impairment, pain intensity, and the health-related quality of life. and then to assess the prognostic significance of a decision to change the postoperative treatment plan to go ahead and see if it is going to matter one way or another.
Oh, Dr. Doski, I just had a question on that first bullet point on the last slide. Does that mean on the distributable, does that mean cell lines will be created from that, or?
Yes, cell lines as well as the genetic sequencing. Yes, ma'am.
Okay, great.
All right, so that was the last slide. That is the study. We're pretty excited because as you've seen, it's really grown into a number of different areas of the process that we have not really paid much attention to before. And the fact that we can go ahead and get a lot of information and hopeful advancement for imaging for those lesions that are or are not more relevant. The fact that we can go ahead and potentially try and make it a little bit easier going through these operations is helpful. And then the biology piece is just, it's wide open. I've had comments from pathologists where, this is a truly unique moment for them to get these kinds of tissues. So I thank you for your attention. I welcome any additional questions. And most importantly, I need everybody to start pushing their doctors to open this study. Having 50 patients accrued a year was a little bit optimistic, just related to the specificity of our population done to reduce the heterogeneity, but it is a fact. And so we definitely need a whole bunch of folks to help get this open and to accrue. So thank you.
Thank you, Dr. Doski. Actually, just to that point, one question I had, and I imagine that a bunch of people have, is if a patient did want to enroll in the study, is this, because it is a COG study, is it available at a COG institution or is not yet? And if a patient wants to enroll, what's the best way to go about that?
It's 48 hours old. Okay, so almost nobody knows about it. It has gone through the central IRB process of the NCI, and it has been approved. We have all of the consent items addressed. And so at this point, it is going to be a push to the principal investigators at each of the cancer institutions to go ahead and open the study. We have the mechanisms in place for central review of the radiology pieces. We have the mechanisms in place for the processing of tissue. We have the radiologist primed and ready to go. I am being schooled in all kinds of data review on a national level that I wish I never had. So we are definitely ready. This will be, as I said, an NCTN, which means that if the organization is part of any of the major national consortiums, all they have to do is ask the NCI to open it. So this is a COG, this is SWOG, this is ECOG, this is even Alliance. I will tell you, I have spent quite a bit of time with the adult organizations, and it's been interesting and it's been telling. And so when I presented, and it was each of the three had the same type of pattern. Well, I'm here to present this. Why do we need this study? There's no question here. Well, I think there is a question, and you try and be gentle in those kinds of moments. And then, well, no, it has been answered. Everybody knows you have to do an open thoracotomy. And within this audience, there would be other people in the audience to say, no, you're completely wrong. Everybody knows it's thoracoscopy. And they would sort of go back and forth arguing each other, at the end of which I would just walk away and say, this is the reason we need the study. This is one where other folks have said we really don't need the study because you can do an open thoracotomy and have almost no physical impact. And then go ahead and have an enhanced recovery after surgery. That's another big buzzword in the surgical world. It's called ERAS, that we have different ERAS patterns in place that really make it unnecessary to even ask the question, because thoracotomy is no big deal.
Unless you're getting one, then it's a really...
That's exactly it, unless you're getting one. So in that regard, I'm hoping that if there are individuals that are going to be specifically bringing this up with different institutions, that there would be a willingness with all of the mechanism in place to open the study at their institution, in which case they're on study.
I have a question just kind of like regarding, I guess, more like surgery in general. Like how long, so like after initial like metastasis and then like initial surgery between the two, how long before you can like say that person relapses it like a second time? How long before you can have another surgery?
If the person relapses, then you can have a surgery immediately, because at that point, that's the end of our study. Well, it's the end of our primary objective of the study. So you could have an operation typically within a week or two for recurrent disease. This is one where the further out you get from the last surgery and the further away you get from the initial presentation, the better it is. The fewer the lesions, the better it is. Thoracoscopy is generally going to be easier to do a reoperation on than a thoracotomy. And so that can be done within, you have to schedule it, and things are still a little bit stupid with COVID, but there should really not be much delay. So it should be done within a week or two. There's really no reason to wait.
Yeah, and then I guess a follow-up question is, you guys are kind of, at least at this point with COVID and everything, and kind of how I guess scheduling may be a little harder to do during this time, and if that like is accounted for in the study.
I wouldn't use the term harder. I would use the term stupid. So it you just have to argue with people that you have to do this. But no, we still will in the setting of oncology. And this is one that is pretty much across the board in the country. For any patients that are having oncology procedures, they are clearly prioritized and they are clearly getting done in the timely manner that they need and deserve. So this is one where if there is a relapse that's picked up, either first relapse or any of the additional relapses, we've had kids with 4 or 5 relapses where we just continue to operate to try and hopefully someday get truly ahead of it all. That it's usually pretty quick.
We had another question come in. So this is great. It says COG is in Canada and we will open at Saint Justine in Montreal. Are SWOG, ECOG, and Alliance potentially in Canada? And can they reach out to adult thoracic surgeons in Montreal?
Please, we would love that. And again, everybody's been sort of waiting. It's been about 8 years worth of windmills. So it's sort of an unusual moment to have finally given birth and have the study available. Now we definitely want all hands on deck to try and open and try and recruit, because it is going to be a little bit trickier related to the requirements that we have put into the process. But as I've explained, that's sort of necessary because we want to be able to try and have a truly well-considered answer at the end of this.
Thank you for the massive and very exciting foresight to have the pathology be such a strong component here. This is something we desperately need in osteosarcoma. We need that data, and we especially need that metastatic tumor data, and to be able to compare to the original tumor. And I think I saw circulating tumor DNA, right?
Yes.
Okay. Yes. Huge. I mean, totally. This is such a big deal. And I have a follow-up question to my so thrilled that this is happening in this way. Do you then report back any possibly actionable data to the patient family as well as to the treating physician?
At this point, it's pretty much research. So we haven't gotten to clinical implications of the results. And in point of fact, I'm not really quite sure. I know there are a couple of big labs. The Crompton lab and the Weiser lab are 2 of the big ones that are going to be processing the ctDNA. In point of fact, the only one we're going to feel confident of getting is going to be the one at time of operation. And so I'm hoping that that will go ahead and establish a model for liquid biopsy for that detection purpose. In terms of the institutions following up and providing material is a little trickier.
I have one more question, just
Sure.
really to Ryan. I'm wondering, because you had the VAT surgery, which you shared at the top, how did that happen? Like, because I know, like, we were treated around the same time, and if you said to anybody, "I'm having VAT surgery," it would be like, oh, wait, what? Don't you know that you need to be having an open thoracotomy? Like, so how did that happen? And did you know about that when that was, like, I know your mom is like so careful about treatment and all of that. So I know all of that's in place. I'm just wondering what that process was like for you.
So at the time, it was only like a small nodule. It might have been like 5 millimeters or something, but definitely like metastatic. But in I guess, in one side of my lung. And the surgeon that I had was super confident with doing VATS. He said he'd done a lot of them, so he was just something he was confident in, and he didn't like. He offered the idea that obviously like the downsides of using VATS versus thoracotomy, he did allow us to choose which one he wanted to do, and we were just kind of had to weigh that decision, and we chose to do VATS just because it was one nodule. There wasn't anything that was picked up, like the radiology, like anything larger, anything above, I think I forget the cutoff point, but there wasn't anything else. And so it was just something that he was confident in doing, and so we just trusted him.
Yeah.
So
did he say he was going to look around as well with the scope?
Yeah, he said he was going to look around. He said he could like use his like a single finger, I think, to go in and like feel like the general area. I don't know how much that helps, obviously, because you can't get the whole lung.
Okay, thanks for sharing that.
And believe it or not, you can actually, if you get a finger in, you can go ahead and with the thoracoscopic instruments, move a significant component of the lung surfaces into the zip code of your finger so that you can feel more than you would think.
So interesting. And I think the part for me that's really interesting on Ryan's case is like hearing from the patient side, like, what did you know about this and what led you to go, no, VATS, or no, absolutely open thoracotomy? That's a pretty pivotal moment. And I think Ryan said something really interesting there, that there was a good part of it that the balance tipped in favor of VATS because the surgeon was that confident.
The randomness of the moment and how that occurred is something that is one of the main factors in trying to have us assess and come up with a much more scientifically sound approach. Yes.
Yeah, and I think if it was like more than just one, or if I had like one in each side, then it might have been like a different story. So I mean, I could say that like, I guess possibly I just got lucky, but it's too hard to ever know.
Your mom does not put luck into the equation. She's like, I'm pretty sure that was a super well thought out on all parties, but
I think for like at least like my quality of life, it definitely like helped out a lot, because obviously not having to have that longer recovery time and being in the hospital for longer. At least.
How long were you in the hospital for?
Like a day or two, maybe like 2 nights. I forget exactly. Yeah, very fast.
Okay, this has been so fun. We can like, I have so many more questions that I just, like we could just keep having this conversation, but we want to give you back your afternoon and probably back to your patients. So thank you, Dr. Doski. I know this has been a long gestation period and you stuck with it. And I really do think this is going to make it better for kids with osteosarcoma, especially with the biology component in there. It's just so huge, but also the recovery time. There's so much to this. And I really hope that people push forward and really ask their doctor about participating in this trial with COG, which is a really important part of the ask.
COG or SWOG or ECOG or Alliance, because they're open, they're openable at all of the NCTN institutions. So it's really, the emphasis is to go as far and wide as we can.
Yes. Okay, and if you don't remember any of this and you're listening, know that this Osteobites and all Osteobites can be found on YouTube, on our MIB Agents YouTube channel, on mibagents.org, on our Osteobites page, or anywhere you get your podcast. If you registered for this Osteobite session, you're going to be emailed the final version of this Osteobites, as well as any links that were discussed. And then next week, I have to tell you about a really cool Osteobites next week. We're having a really unique kind of Osteobites. We're talking with Dr. Kurt Weiss, who is an osteo warrior, an amputee, an osteosarcoma researcher, and surgeon. I'm going to add in rapper, like mogul. I don't know. There's so many good parts of Dr. Weiss. He's at University of Pittsburgh. He's going to be sharing the Bite stage with MIB Agents Junior Advisory Board President, Kara Skrubis, who's also an osteo warrior and also an amputee. They're going to be talking about amputation surgery for osteosarcoma from both the physician, surgeon's perspective and the patient's perspective. So that's going to be really interesting. Bring your questions for that. Until then, Dr. Doski, thank you so much. Ryan and Christina, thank you so much. And thanks everybody for joining today. Great session. Thanks again.